Good morning. Can y'all hear me? All right. All right, guys. Thank y'all for being here. I apologize for the 15-minute delay. We were waiting on Representative Kirby. It appears he is not going to make it. Representative Howard is unable to be here today as well. We saw him at the biennial yesterday, and we knew he wasn't going to be here. So here's what we're going to do today. First of all, thank you all for being here. We have several departments. There were several in our conversations and in some of the we've gotten a great deal of emails and recommendations whether they are verbally, people we've met, we've talked to associations, we've got some formal recommendation from associations, we've had some great testimony here in 8 hours of testimony previously. And so there were a couple of areas, a couple of departments that we wanted to hear from. Both of them are here today. Well, actually, there's 3 departments because we've also asked very briefly. There's a recurring conversation about the new fingerprint bill, which was SB 406 that we passed last legislative session. And so we have Ms. Brandy here from the Department of Community Health who is going to, and yes, we do have Brandy on the agenda. Yep. Brandy Sylvan is going to speak first to kind of update us and all of you that are here on where we are with the new vendor and moving forward with accessibility on the new live scanning. I think everyone here is aware of where we're headed with the impact of SB 406. And so we'll begin with that, and then we're going to have Jodan Banker. Is that correct? Yes. Ms. Banker? And with the Technical College System of Georgia, and Ms. Susan Adams with DeKalb, speak to us on some issues that we had regarding child care and also with technical college training for CNAs, et cetera, and proxy caregiving. We have some recommendations related to proxy caregiving that we might feel like could be useful for the technical college system as well. And so we're going to do that, and then, just so you all know, we're taking recommendations today only. We've heard 8 hours of fantastic testimony, which has emphasized concretely that this is a real issue. The departments have said it, advocates have said it, providers have said it, individuals have said it. Everybody has echoed that the premise of this entire resolution, H.R. 1257, is indeed a problem and a crisis going forward. Now, today, we're only going to talk about what we do to fix that, right? So we don't need to hear about the problem. Only recommendations today. Okay, Ms. Brandy Sylvan, who represents the Department of Community Health. Thank you. And I'm going to get right there. Good morning.
Good morning, Chairman Petrie, members of the committee. As Chairman Petrie said, my name is Brandy Sylvan. I'm the Director of Government Relations with the Department of Community Health. I'd like to thank all of you for your commitment to examining this critical issue in our state's healthcare landscape. Testimony from previous meetings has demonstrated how important it is that we address the challenges of ensuring an adequate and qualified workforce to meet the needs of our citizens. Last year, the General Assembly passed Senate Bill 406, which aims to improve patient safety by requiring direct care employees to undergo a national fingerprint-based background check prior to employment. The intent of this legislation is to better protect vulnerable populations, not to be a hindrance to workforce development. The Caregivers Registry, which will return the results of these background checks, will be active in October of 2019. The Georgia Bureau of Investigation is currently working with a vendor to examine print site locations and identify areas in the state with additional need. We will continue to work with GBI and providers to prioritize the identification of quality candidates for employment while easing the impact on potential employers. We look forward to this continued work, and thank you for the opportunity to provide this update. And if y'all have any questions, I'm certainly happy to do my best to answer them. But I understand the primary concern was with the access to the print sites, and I know that GBI is currently working with a vendor to identify areas in the state that have additional need.
Okay, just a couple of questions, and that way everybody is aware. So the new vendor has not yet been.
I believe that
they are. That contract has not been awarded, or it has.
I believe it has.
Okay, it has.
I would want to get confirmation on that from the Bureau of Investigation, but I believe it has.
And as was agreed during the, all of the machinations of passing that legislation, the department was very clear that there would be ample outlets for literally every caregiver in the state to be fingerprinted. We're thrilled about that. I think this is a great piece of legislation, but it only works if you have adequate
Yes, sir.
capacity. And so so you'll check on that, maybe let us know. But
Absolutely.
the word is, in the department, everybody is still solid on insisting that we have the locations, every county, access to every caregiver, no matter how rural, no matter how urban. And in those urban areas, you have to have multiple outlets, or you'll have a huge bottleneck, and that keeps people from going to work, and it keeps people from getting services, moreover.
Yes, sir.
And so the other issue is, you mentioned a recurring theme we've gotten here as a potential solution is a registry. And so, as you mentioned, SB 406 created a registry that will also be available to private individuals.
Correct.
Which I think is a good thing. But that registry is expressly going to be relate expressly to live scan fingerprints.
Correct.
And and you and I discussed this at the biennial. I want to make sure everyone is aware of this. That registry, it can't be beefed up, if you will. It can't be improved to include other types of data. It's expressly for that purpose. Is that not correct?
Yes, sir, that is correct. And that's based off of what the FBI has approved us displaying on this registry. So unfortunately, with this particular registry, we do not have the opportunity to expand it to include training, educations, credentialing, that
Gotcha.
kind of information.
That's one of the recommendations we've heard recurring that we'll talk about later, but I think so. What you've made very clear is that route is not, you can't piggyback on that.
Correct.
So if we do that, there will be a separate registry. And of course, we already have a CNA registry, and we'll talk about that today as well. I'm sure that's been a recurring recommendation as well from folks.
Yes, sir.
So thank you very much. Are there any questions for Ms. Sylvan? No, thank you.
Thank
And
you.
thank you for all the department has done to help us in this regard.
Happy to help. Thank you.
Okay, Mr. Joe Dan Banker is with the Technical College System of Georgia. He is Assistant Commissioner for Workforce Development. And Mr. Banker, thank you for being here. One of the issues, and I'm going to look here, I've tried to, we have gotten volumes of information. Tara has done us a summary of sorts. I've done my own summary, trying to lump recommendations into categories, if you will. But one of the recurring themes is training.
Yes, sir.
And so, I want to make sure everyone here knows this. One of the first things that we have heard over and over is that we need to make sure that everybody that wants to be a CNA has the ability to do so. So I want to make sure that I state this correctly. Right now in Georgia, CNA training and certification is one of our 12 or 17 special.
It is part of the Hope Career Grant, yes,
It's
sir.
one of our Hope
Yes.
Career Grant specialties.
Yes, sir.
And so that is free for any individual
Tuition and fees are free if you're part of that, yes, sir.
if you're part of that. So that's important. And I think that's, that's good for this industry. There have been other questions, and I'm just going to tell you so then you can present. But there's been conversations about soft skills, conversations about internships. There have been conversations about CNA training being offered in other locations, off-site, rather than in an institutional setting. Customarily, training is done, the clinical piece is done in skilled nursing facilities.
Yes, sir.
There's conversations about that being offered in community-based settings. And so those are the kinds of things we're that we're seeing, and there's been a lot of conversation about the proxy caregiving, and maybe is there a piece or a sub-certification we could add to the CNA training? But let's hear from you first, but I wanted to make sure, because I had not met you before today, I wanted to make sure you knew kind of what the questions were that led us to feel like it'd be helpful to have you here.
Yes, sir.
Okay, thank you, sir.
Well, CNA is pretty universal. Can you still hear me? Yeah, there we go. It's pretty universal across our state in a lot of different venues. 17 of our 22 technical colleges offer it. When it's offered through the technical college, it's a certificate that can be taken and graduated from in a single semester. The requirements in order to sit for the exam for certification is you have to know the knowledge to take that written exam, and then you have to have at least 45 contact hours of clinical. And so we have all that within our certificate. We also have soft skills. Every one of our programs at the technical college have a work ethic plan that's loaded into that, and we have 10 traits of a good work ethic that we go over with each of our students. And they are graded on that in a separate piece from their grades in the actual courses for the academics. And as we said earlier, it is part of the Hope Career Grant. If you look at the 17, you won't see CNA, but it's underneath the nursing category. It's included in with that. Last year, 2018, academic year 2018, we had 2,417 graduates. Our placement, and by placement I mean they have been placed in field or out of field related, so they're still in a health care facility working with patients, or they have continued on with their education to become a nurse or a medical assistant or a phlebotomist or whatever they desire based on what they've learned in their clinical. That normally is 99%. And that's what it was for those placed out of 2018 graduation class. Right this moment across our system, we have 1,491 students enrolled in a CNA course. About 1,300 of those are dual enrolled with the high schools. And that's another point is in a high school, a student, they can elect to become a college student dually enrolled and go through CNA. A lot of our high schools also offer CNA on their own. As I said, the requirements are 45 hours, and then you know that information, but there is one other I didn't mention, and you have to be 18 to actually sit for the exam. So if you, as in most of our students, if they're coming through at the high school level, sometimes they may have to wait a few months before they turn 18 before they can actually take the exam. Again, just about everybody has really good placement because you wouldn't have had me here if it wasn't for the fact that there's a drive for that. We just recently merged workforce development with TCSG, so I want to give you a little bit of that side of it as well. We have 19 local boards throughout the state, and all of those throughout the year also provide support for CNA training. Now, if they come to a technical college, their tuition and fees are covered, but the student still has to buy their scrubs, their uniforms, textbooks, things like that. That could come under the support services that WIOA could cover. And in addition to that, child care or transportation, any other kinds of needs they might have. So the combination there makes for a pretty good synergy. That's one of the good reasons why we've made that merger. There's 578 participants right now, active participants who are enrolled in a CNA program right now. Now, what I don't have for you is the actual cross reference of that, how many of those 578 are actually in a technical college. We're working those data exchanges now, so eventually I'll be able to make those kind of reports to you. But those 578, just like the 1,400 that are currently enrolled through the technical colleges, are spread pretty evenly across the state. Metro area is a little bit higher due to the higher concentration of hospitals and population. That having been said, there are other venues that can do CNA. I believe you alluded to that. Hospitals can do it. Assisted care learning or assisted care facilities can also do their own internal training. Again, those might cost the participants some funds to do that. If they come through WIOA, that can be supported in that way. But as of for the last 12 months, there have been active 4,754 postings for CNA. So there is a need. There's a draw for that, and currently TCSG is falling just a little bit short of that by itself. But if we were to bring in data from all the other ones, we might get a little bit closer. But I believe there's always an opening more than we have graduates coming out. It is a entry-level position. So a lot of cases, if somebody gets into it, they think they want to be into healthcare, they get into it and they decide, no, patient care is not for me. I did that in college. They would then shift over to something else. Another avenue is they get into it, they see they like it, and they start seeing other higher level positions like nurse, medical assisting, that they would rather get into, and so they can come back to school and get that training and go into that. So there is a good turnover rate in all of the places that hire. So there's always going to be a pretty tight need. So we just need to ramp up. I believe with the synergy of workforce and TCSG, we might get closer to that mark in the next year or two. Are there any questions? Oh, yes, sir. Well, I'll provide a white paper for all of you. Neil, I'll give them to Neil, and Neil can provide that to you, give you these data. And I also have, by each one of our local areas, the numbers that they're doing at this very moment. Now that changes rapidly because it is a short-term training program. Thank you. Yes, sir.
Mr. Banker, so my question, so how many of your positions, 99% placement rate, that's strong, and it
That's
doesn't
very
surprise,
strong.
I don't think it surprises anybody in this room, obviously, as you
But
suggested, that's why we're here.
that includes just another healthcare field or continued education.
Sure.
Yes, sir.
But, and of course, you spoke to the whole entry level and the migration. We want that. We want
Yes,
people
sir.
to migrate. We believe that's one of the most important reasons this is important. We want to create a better career ladder, but moreover, we want people to become LPNs
Yes, sir.
and to continue to advance in society. But that is why, to go back to where we started, is why we have to have a constant pool of people coming in.
Yes, sir.
So my question for you is this: how many other professions, you have so many under your domain, have a 99% placement rate when you have them graduate?
Throughout TCSG, we are typically 95 to 98, 99%
Wow, that's
placement
fantastic.
rate. There are some years and some fields where that will drop, and
Yeah.
that's due to the economy or cases of that matter. But TCSG is only doing those programs that are needed by the industry in the area, or we don't do them. We're not searching for the Higgs boson particle. We're looking to put people to work.
Because of the targeted approach the department has taken,
sir.
y'all, that is really, we should all be proud of what you guys are accomplishing there.
Thank
That's
you.
impressive.
The work is in conjunction with the industry fields. We have industry partners that tell us what they need all along the way.
Very good. Any other questions? I will ask, if you don't mind, I'm going to look at some of the comments that I had made and ask
Yes,
you a
sir.
couple of questions.
Yes, sir.
One of the, there is a proxy caregiver process in this state that allows nurses to delegate skilled services to caregivers
Yes, sir.
who are not licensed. And so, and there's a whole statute built around that, and there's a whole set of rules and regulations around that. One of the things that we've heard over and over is about, a career ladder. If there was a ancillary certification for a CNA to maybe get some kind of proxy caregiver training before they go to work, that individual might then be more skilled at taking, not every caregiver is one you want to proxy, but you might recognize them as having special skills that might cause you to pay them more. Because over and over again, we're hearing we got to have a way to keep people in the field to help them to earn more, to climb a ladder. The thought is that might be one way to do it. And we know that the proxy caregiver process is going to require, individualized training by that nurse with that individual, but you would know you have a person with the raw material who's already gone through some of that training.
Yes, sir.
And there might be a way, if we work with DCH, to maybe come up with a way that it might reduce some of the training the provider has to do because they've already done it, perhaps through the technical college system. And so what are your thoughts on that? Does that sound reasonable? And what are your thoughts? I know it's a very quick training, and I understand that, but...
Well, we do introduce them to the idea of proxy training, the whole idea that you may not dispense drugs in terms of breaking them out and putting them in, but somebody else could do that and hand them to you and say, provide it at 2 p.m. or whatever the case is. We brief the students on that. We do not currently have a training module on that. That would not be a bad idea. In terms of what you said about a ladder, that's basically how we've organized all of our programs where there is increasing levels of knowledge or competencies. And so CNA would then naturally work its way up through a variety of different medical fields, most notably nursing, LPN, but medical assisting is, a lot of them move into that field as well. There's actually a pretty broad, wide need for the medical assistant. They do, they'll take your blood pressure and your temperature as you come in, and then they do your records and stuff. So everything that we do when we're presenting it to the student, regardless of where they come into, we tell them about the levels of training above them. And if we get to the associate degree level, then we start talking to them about the university system.
But if you had if there was a recommendation to maybe try to, because increasingly what's happening is that we're having to, we don't have the manpower, and so we're having to push down. We also don't, it's not just caregivers, by the way, it's also nurses. Right. We have a nursing shortage, and so we're having to delegate more and more. So that might be a reasonable, would you think that would be a reasonable recommendation to try to maybe have some kind of coursework that might be incorporated into CNA training, and then they could carry that with them to employers
as they go forward? Yes, sir.
Okay.
It sure
and
would.
We'd have to work with you guys on that if that was a but that doesn't sound unreasonable.
It does not. No,
okay.
Sir. And there's a lot of ways that you could work that.
Okay,
in other words,
good.
We could do it separately, like you're saying, and include it in the curriculum, or maybe work with the national accreditors to add it in as part of CNA for the certification.
Gotcha. I'm going to ask you a couple more that I had on the list from going through all the data yesterday. So just to make sure I understand, and some of these just because I don't know the answer. High school diploma or GED, that is not required for them to begin the process.
No, sir.
Okay, just that. So that would not be a barrier.
No, sir.
Okay. And I alluded to, you've answered the soft skill issue. Y'all are addressing soft skills.
Yes, sir.
I'm proud to hear that.
Now, in regards to that, I don't know where you learned your work ethic. I learned it from mom and dad.
Mom and dad. It's the things mama taught you.
Right.
That's what I call soft skills. Most
without
people
that model,
a lot of people don't have them.
Yeah, that would be a better model, but then we do our best with it in the classroom.
You're doing the best you can. But somebody's got to do it, and unfortunately, too many parents don't. But you can't come to work in a Bud Light T-shirt.
And late.
Yeah,
that's
and,
right.
And appalled that you think they're supposed to be on time. So don't get me started. But so one other issue that I want to capture you while we're fortunate to have you here. The other issue I mentioned was about CNA training. That's been had a good number of people speak to that issue. So CNA training, you mentioned in hospital settings and nursing home settings. What about home and community-based settings? What about training taking place in other settings? Would you find that to be a reasonable recommendation?
I do find that, and then I believe some of our colleges, out of necessity, have to do it that way. They'll place them in their clinical in any place where they can. There's a list of competencies that they need to be exposed to, and if in a home-based area that is covered and there's a proper supervision in place, then
Okay.
we'll place them there.
Yeah,
Yes,
it'd
sir.
have to be, y'all would have to ensure
Yeah.
you have the same quality, but
Yes,
it's
sir.
more about, I think there's a mindset that we've seen that if people are exposed to community-based care, they might be more likely to want to do it.
Do it,
And in
yes, sir.
fact, I had a lady send me a long email talking about how she had been a nurse for so many years in a hospital setting, and when she discovered home-based nursing, she was an RN, really not directly related to what we're doing here, but she said, she was advocating that for RNs as well to do the same thing, to be exposed to community-based. Because she said, if I had known it was like this, I'd have done it my entire career. And so I think where caregivers might be exposed to it, they might be more inclined to say, yeah, we want to work in the community rather than work in an institutional setting. So it sounds like that's not
Very
an
reasonable.
unreasonable
And in fact,
request.
happens in some places.
It happens already. I did not know that. Okay. Okay, any questions from the committee regarding any of these issues?
There's I wouldn't call it a fight, but you're always looking for clinical spots, regardless of whether it's for a nurse or a pharmacy assistant, whatever the case is. So in that struggle, sometimes we go out of the hospital setting for sure. Yes, sir.
Thank you. Well, that has been very helpful to me.
Let me ask one question, if I may. Something that really was astonishing to me at biennial, I think it was Monday, 62% of all students that come to the Technical Association read at a 6th grade level.
Reading is a serious issue.
Can I clarify that?
Yeah.
So I was there when our commissioner spoke to the group on Monday. And
Thank
so
you, because I'm going to use that tomorrow.
What he was referring to was in our adult education. So a lot of what we do is we do training for the GED testing. But when
Okay.
you have 62% of your students in that category that can't read on anything but a 6th grade or below level, it becomes more of a literacy training than it is teaching for the GED.
Okay, and one of the things he did say after 2 years, the hope was to bring them up to 8th grade level, to where they could read the paper, they could do other. And the reason I'm going here with that, this is a little bit off schedule. I have teachers. My wife's a teacher, daughters are teachers, and it's amazing the reading that kids are graduating, and we keep pushing them on through the system. But I didn't mean that as a slight. I have your back and support everything in our
Yes,
technical colleges. But I just, when I heard that, I thought, you're the second man in charge. I wanted to know exactly.
Well, the students actually in college are just like students at University of Georgia.
Right.
They have to meet those same types of placement level. We don't have entrance requirements, but we do have placement requirements.
Well,
And by definition, those in our adult education program would not have graduated from high school.
good. Thank you.
Yes, sir.
Very good, quick response.
Thank you.
Thank you, sir. That was very helpful. And I think the issue you just spoke to relates to the whole issue of making sure there are people that make great caregivers that don't have a GED, that didn't.
Right.
Listen, we need caregivers that have compassion and a heart.
Right.
And so we want to make sure we're not leaving them behind. They need to know how to pass a TOEFL. We need to know that they're literate enough.
Yes, sir.
But they may not have passed high school, and you've made that clear. That is not a barrier in this state to individuals becoming certified as a nursing assistant if they choose to do so.
Yes, sir.
And that, I think, was the question. So, all right. Well, sir, thank you. That has been very helpful to
Thank you.
me, and I hope to everyone here today.
And I'll provide Neil with that white paper so you can have all the data I
Thank
just
you.
talked about.
Thank
Yes,
you,
sir.
Commissioner. You've been so helpful. All right, Miss Susan Adams. with DECAL. That is the Department of Early Care and Learning.
That's right.
Got to make sure I get all my, we get a lot of acronyms when we come up here, Lord. But thank you for being here, and I spoke to
Sure.
the commissioner at the biennial that Representative Donahue just mentioned, and she was just delightful, and told me I'd be thrilled to meet you. And I
Well,
am.
that's very kind. We appreciate you inviting us here today. I would say that in addition to what I'm going to talk to you about today, from a very personal point, my family recently, my stepfather had Parkinson's, and having a caregiver that was able to work in our home allowed him to spend the last few years of his life to live independently with my mother. So I know and have worked directly with people in this workforce and know how important it is. So what we're going to talk about, I'm going to share today, is talk about some of the ways that our department might support this workforce and thinking about their needs around their children. We know that a lot of the population here are women who are of low income and have children and families of their own. And so I'm just going to flip through a couple of slides and talk to you about some of the ways we might connect. Just as some background, we are the Department of Early Care and Learning. We work with services for kids birth to 5. So things like licensed and monitoring childcare, our pre-K program, our federal quality initiatives. So a couple of things to think about that we're going to talk about. Some areas we might be able to assist: our pre-K program, our child care and parent services program, which is our subsidy program, the Early Head Start program, and the Head Start program. So you're probably familiar with our Georgia pre-K program. This program serves about 60% of our 4-year-olds across the state, and is funded by the Georgia Lottery for Education. All the requirements are for this program is a child must be 4 by September 1st, and that family must lay their head to sleep in Georgia. So there isn't an income eligibility. This is a school day, school year program, an instructional program for children. It's free of charge for the 6.5 hours of the school day, and then there are scholarships available for before-after care services that a family might need for a child. So certainly that's one option. Another option to really explore is the Child Care and Parent Services Program. This is the child care subsidy program that is federally funded. It allows child care scholarships to assist families of low income to afford the cost of child care. In this program, it covers children who are 12 years of age or younger, or 17 years of age or younger with qualifying needs. So that might be a child with a disability or special health impairment. In this program, it is an income eligible program, so families must not exceed 50% of the state median income, and the parents are required to be in work or be in school or training or participate in other work-related activities, like some families' parents might be in job search. This program in particular is one that would be of assistance to this population. I know you heard from Joe Dan, and we have a big partnership with him working with the technical schools to put people that are going through the technical schools to get these scholarships for childcare, because a high number of the population in the technical school are mothers with young children. And so we have a big program with them that looks at a 2-generation approach that gets these students in technical college these child care scholarships. The other 2 programs I'm going to quickly talk about are federally funded. Early Head Start is a program for income eligible families, and it serves infants and toddlers up to the age of 3 and pregnant mothers. This is a more intensive preschool program where they offer child care, but then also wraparound services, so things like transportation or supporting families and other needs they might have. And then the companion program for that is the Head Start program that serves kids 3 to 5. And so this program is also income eligible and provides those same services for kids up to kindergarten. So those are some of the options for the population as they think about their child care needs. And I'm going to stop right there and allow you to ask any questions you might have.
I have a comment.
Sure.
After the conference this week, I think there's going to be a little bit of a competition between the House and the Senate with early reading. Did you guys pick up on that? I got to read with the pre-K 4 in Spalding County, and anybody that can go do that, you need to do it. I was also in a meeting last week discussing low birth weights, infant mortality, all that business. And the biggest thing is teaching our children to read by the 3rd grade. That's the mile marker.
Right.
So I think that's going to be a good program, and I'm excited that this is in place so that we can move forward. Thank you, Susan, for all you do.
Well, thank you.
Appreciate it.
And we appreciate you thinking about the youngest kids. And I will say, as we think about kids being able to read by 3rd grade, one of the things you really want to focus on is that kids have multiple years of high-quality teaching and instruction. So making sure kids are in high-quality infant and toddler classrooms that go into a Georgia pre-K classroom, and then have those same years of high-quality instruction in K1 and 2, that's what makes the difference for that reading.
Right. Can I ask one more thing, Mr. Chairman? They also talked about certification of pre-K programs. Can you speak to that a little bit? Apparently, there's been some pre-K programs that whoever owns them, they're not willing or able to come up to that standard.
Sure.
So that was a big discussion among us too. Can you speak to that?
So as we think about preschool services for kids, there's a couple of different ways that our department supports programs. Our Georgia pre-K program are all lottery-funded classrooms, and they're all going to be in licensed child care programs or accredited school systems. And so all of them are meeting very specific high-quality standards. Then we also monitor and license child care programs, which would be child care learning centers, and then also family learning homes, which are homes where people are paying for up to 6 children for pay. But then we also work with programs that might be exempt from licensure, meaning that maybe they don't serve kids full day, or they only serve kids a half-day program or a specific age of children. And so those programs are exempt from licensure. Our department has been working to review all the exempt programs in the state because of some new federal requirements to make sure that they truly meet the exemption categories. And there are some programs that are being discovered that now either need to change their services to meet their exemption category, meaning they only serve kids for a short amount of time or a specific age of children, or those programs are going to have to work with the department to become licensed. And so there's a process to work with them to come into license, but they have to fit in one of those buckets. So I think that's probably where you're hearing some of that. And it's some changes with the federal requirements that the agency is having to work with programs to meet those requirements.
Okay. Thank you.
You're welcome.
Mention one thing first, just to piggyback on what Representative Mathias said. This is a little bit of a tangent, but I looked this up. I sent a text. We were at the biennial, listening to the same discussion. I sent a text. I have 2 very good-looking grand twins that were born 7 months ago. Good-looking boys, 2 boys. And I sent this text to my daughter while we were listening there, while we were sitting there listening, to the commissioner of the department, to your commissioner. Mm-hmm. And I want everybody here to hear this. This is profound. 85%, I told my daughter, of human brain development occurs in the first 3 years of life. And what she said that was very powerful to me was that quote, "The amount of loving words spoken in the home in the first 3 years of life are critical to success." I thought that was, and of course my daughter is the most wonderful mother, but I wanted her to recognize that, language, reading, and reading to your children is so important, to echo your point. But just that was powerful to me as well. I think it affected all of us, it sounds like.
Thank you, Mr. Chairman. And you covered a little part of what I was going to talk about. My grandchildren are as good looking as your grandchildren. My daughter's a great mother. No,
Yeah, a lot of
there's
competition.
see the competition. The part that I notice the most, every time I'm on a committee, if it's in my expertise of what I know is in real estate or different things, transportation, I usually can come up with a solution. I always told each person that come to my office with a problem, what's the solution? So I always ask, if you had a Christmas, it's just 13 days away, what would your number one Christmas wish be to fix or help the problem? And what would be a second as a follow-up?
So many of the issues that you're talking about with the caregiver workforce are same parallel issues for the early care and education workforce. We have a low wage, many times low income population with a lot of turnover, and childcare is expensive. And so we have families that struggle to pay the cost of childcare, which in turn has programs that mean that they struggle to pay the wages that may support teachers in doing things like going back to school to get credentials or increasing their skills. So as we think about those supports, and even some of the recommendations you're thinking about for the caregiver population, I would also have you to think about for the birth to 5 population and think about the workforce. As we think about those loving words and interactions that need to happen with parents, we also have to have a workforce that can give that same kind of support, because most of our families now have at least one parent that is full-time in the workforce, and most families have 2. And so those children need to have the same types of relationships with those teachers and those programs. And what it takes is someone that has a caring, established relationship with that child, who has those loving words, but also has that connection. So as we think about that, how do we put those supports in to support a stable workforce in 0 to 5?
Thank you. Follow up, if I may. What percentage would you say that you are seeing single parents every year grow more and more? With that, we make choices. And I would like to understand how we deal with this, because it's a cancer that continuously is growing every year. 3 years ago, I sat in on a committee, and I apologize. Somebody shook my hand at biennial that evidently has started getting my throat to leave. However, how do we work toward solving this problem? I went back 3 years ago and started substitute teaching, not for the $60, but I was sitting in a committee and I heard a certain senator make comments that weren't true. And I called that senator upon that and told him that wasn't the way it was. But I went there to where I could spend time with students. When I walk into the classroom, I let them know who I am, just by name, not what I do. But I tell them I believe in them and that I believe they're there for a reason and their future is bright if they apply themselves. But I let them know I'm in charge of that class. I always take that when I coached ball. From everything I've done, I've always tried to let that young person know I love you's a big word. But then again, I watch so many that has a mom, no dad. She's a meth head or she has some type of drug problem. but we have seen that change with certain counseling and certain help. I've seen it to where the father, he never shows up. And when I had the time or have the time to speak with these young kids, it's amazing to see what just a little bit of time does for them. But there's so many that would sit in a classroom and they would sit there and never have a word to say. And when you start to talk to them, there's so much you learn by spending time with them. But I really want to see why or how we're going to stop this. And we just keep throwing money at so many of these situations. In your expertise, what would be the number one thing that you would try to stop this?
So there are a couple of things that you said that were really important. It is about children, young adults, infants, toddlers, having adults in their lives that they know care for them and that are stable. I can't speak to all of the issues with families and the breakdown there, but we also know that research will show is that if a child has someone that invests in them and they have that person, then that is a child that's more likely to be successful. One of the things that our agency is really looking at is how do we think about and educate all the people who touch children, whether it's a child care director, an elementary school principal, or a teacher, and make sure they have the skills to understand how to create a relationship with every child, even those that are challenging, and then that they also understand trauma-informed care. One of the things that we have to understand is that many of our children are coming from experiences where they're experiencing trauma at a very young age, and it affects even infants. And trauma could come from things that are going on in the household, unstable parenting, drug use, and we know with the opioid crisis, there's more of that. But we need to make sure that our people that are working with our children understand, what does trauma, how does it impact a child? How does it change some of their brain chemistry, how they react to that? And then how, as I, the adult in that situation, deal with that child? And there are specific strategies that can help so that you can create relationships, so you can help that child be successful. And how do we think about getting those strategies and that support out to the people who work with kids? We're working with Georgia State University right now, and they have some really excellent trauma-informed care to look at how do we support the birth to 5 workforce in that.
Thank you.
And thank you, Representative Donahue. You know, it's your question relates directly to this. The reason we wanted DECAL here today was because, again, we're trying to speak to the loose ends with the recurring themes, was that access to child care is a big issue for us. But you're right. If you had more stable homes, you would have less of a problem with the need for child care. So very relevant. And interesting thing, you know, we read, you know, if we're good legislators, we read constantly, and we do. The three of us do, that's for sure. But, you know, it's interesting, when you look at school performance, children, regardless of race or income, who live in 2-parent stable households essentially have the same outcomes as all the others in that category, regardless of demographics. And so it is indeed another crisis for another time to address, but it tangents this committee. You are dead on, and so I appreciate your question. I want to ask you the main theme here was about availability. So you've given us great information. We're doing a great job in this state. We're doing things that, quite frankly, I think we're doing things that a lot of other states aren't doing to offer through HOPE and otherwise with pre-K. But I want to ask you, you mentioned 60% of our kids in this state are on our HOPE pre-K. So talk to us about where are the gaps, where are people not getting, where are individuals not having access to child care so that they can be unencumbered to work more, because obviously that relates directly to this. We want to make sure that if somebody wants to work as a caregiver in the workforce, they have the ability to do so. And you were absolutely correct in that this workforce is primarily females, overwhelmingly, and females with children. And so help us to understand the availability of childcare, and is there anything we can improve? What can we do to make it better so it is available to everybody who needs it?
Sure. So as we think about our lottery-funded pre-K program, we do serve about 60% of the population of 4-year-olds. Probably about 75% of the 4-year-old population is probably where we want to get to. There's always going to be a population of kids and whose families are choosing another option, and we want to support that. They're going to stay home with mom. They're being kept by grandmother. They're in a half-day program. As long as that child's getting the stimulation that they need, we want to honor those parent choices. There are still some access issues with our pre-K program. We have a waiting list for it. I'll say that with access with pre-K, we have some counties that about 75% of our counties serve 75 or more of their kids. So we're doing about 75% of our counties serve at least 75% of their 4-year-olds. So that's pretty good. There are some areas, mostly our larger metro counties, Fulton, Gwinnett, Clayton, Cobb, where we have some access issues, and it has more to do with having high-quality venues and schools to support kids, and so we're working on some options there. As we think about the birth to 5 kind of services for childcare across the state, I would say we do have some areas that have what we would call childcare deserts, so they're more of our rural areas where there isn't childcare available. And then also the other thing we're building capacity for, which would be particular to this population, is all care that it might be alternate hours. So people that are working in the evenings, who are doing shift work or weekend work, oftentimes getting childcare is more difficult because there are a limited number of providers that provide that kind of care. Many times our family child care homes, which are individuals who are licensed to care for children in their homes, can fill those gaps for things like shift work. Some families need overnight care or weekend care. But that's where you're going to see a lot of the gaps.
You sparked something. If it's an overnight facility, those are licensed also.
So there are child care programs and also family learning homes that are licensed and can do 24-hour care. Then we also have a small population of people that are subsidized to do care that's family, friend, and neighbor care, which would be caring for 1 or 2 children, and I'm subsidized to do that, but I wouldn't be licensed or meet the definition of needing to be licensed. But that's a very smaller population. But it could be a grandmother who's caring for a grandchild, a neighbor who might be caring, but it's only for a very limited number of children.
Limited in the, I'm sorry, can I ask?
The number, sure.
Limited in the amount of children in the home? Because it's
That they're
family?
getting, correct, for pay. So they're subsidized, so it's called family, friend, or neighbor care. And we don't pay a lot across the state, but it's a family member who's applied for our department to receive a scholarship or a subsidy payment to pay for a child in their own home, and it's usually 1 or 2.
Gotcha. Now, are those folks under the fingerprint law too?
I would have to check on that. We do a health and safety visit with them and check things like we provide them a fire extinguisher and look at those things. Do you know, Ryan?
Yes. Thank you for the question. Yes, they do have to get a background check at a national CRC, just like all our other child care providers
you.
in the state of Georgia.
Thank you.
Thank you. That eased my mind. I was
Yeah, I thought
getting a
so, but I
little
wasn't sure.
anxious there. Thank you.
Okay, I'm confused on one thing.
Sure.
So not everybody wants pre-K, absolutely.
Correct.
I mean, so I want to make sure we're dealing with accurate numbers here when I look
Sure.
at this. I'm more interested in the way, people that need it
Who've applied.
who aren't getting it.
Correct.
So, because, when you talk about the 60%, I mean, there could be 40% of people that want to keep their children at home. I mean, that's absolutely. So tell me about the waiting
Sure.
list. So tell me about the waiting list. People
So
who
for-
need it can't get it.
For a lottery-funded pre-K program, we carry a waiting list about 5,000 children. These are children whose families have applied for a pre-K slot and do not have access either to any program in their area or to the program of maybe their choice in their area. So there's a little bit of caveat there. So in some areas, and a parent, there may be a slot available, but they may be wanting to go to only a particular program, or they might have some other need, like they need transportation.
All right, let me ask you a question, because I want to, again, with the focus on trying to find
Sure.
solutions, if there is a solution, so it isn't about pre-K funding. The money's there. That's not the problem. Is that correct?
So
I need to understand.
Yeah.
It sounds like if there's not a provider of services in an area, that's a different issue.
Correct.
That's a free market issue where there's not a child care center
Right.
in Eccles County
Right.
for some reason. But does it relate to the funding
in our
of
area,
slots,
yes.
to use that term?
So a lot of the issues around access have more to do with a capacity of local programs, either in the school system or childcare, to also serve them. Oh, the only other caveat I'd give is that 5,000 number of kids on a waiting list only represents families who had access or knowledge to apply. We also know there are some areas where families don't apply because there's not a program that meets their needs, or it's not close enough, or they need transportation. So there are also some families that are more difficult to capture but still need services. So that really represents who applied. We're right now
Okay.
actually doing a big study with the Carl Vincent Center of Government to do some surveys and some focus groups on the pre-K waiting list, and we'll have that in January that will better understand what does it mean to be on a waiting list. Does that mean I'm looking for a particular program, or am I not attending because I have to have transportation, to better understand that data that we have.
Okay, because some of those, it sounds like, we're going to move on, but this has been very helpful. Some of those people may not be satisfied. Just make sure I'm accurate. They may not be satisfied with the Hope-funded pre-K that is available in their community. They may be going somewhere else, private sector.
Correct.
And going wherever they choose.
Correct.
So, and the reason I point that out, that doesn't mean there's 5,000 kids that aren't getting childcare or
Correct.
pre-K. It means there's 5,000 of them that are on a waiting list.
Correct.
A certain number of them are, maybe overwhelming majority of them are getting it somewhere or in another program. Is that correct or not?
Correct.
Okay.
So that's why we're doing a study on the waiting list to better understand. We know that the large majority of those families, if there was a pre-K slot available in their area, they probably would take it. But there are a portion of the families, just from our and in specific counties too, where children didn't get the pre-K slot of their choice, so their families are taking advantage of any vacancies in their area.
All right, last question, then
Sure.
Representative Donahue's got one for you.
All right.
Last question. So going back to Representative Donahue's question, because I think we're seeing there's not we're not Georgia's doing a pretty good job, it sounds like, with obviously there's some gaps, and we
Yes.
got a lot of rural areas where there's gaps for everything. So if you could, what would you do if you wanted to resolve tomorrow or by Christmas, as Representative Donahue said,
My Christmas
the
wish-
5,000 people problem? What would we do if we could fix that? What would it take to fix that? Do you or the gentleman in the back as well, who's with you? Do y'all have? We want to hear from you. That's what we're here for. What could be done to solve that if we could wave a magic wand and do it?
I think there's been a lot of discussions around the access issues. The lottery funds are specifically for slots for children.
Okay.
And so as the agency uses those funds, they're for existing programs that can serve children. And in some areas, there are places where access is limited because there isn't the facility. So looking at issues around addressing that.
But, and I'm not pushing you, but that isn't a solution. So you're looking at, so access is the problem. I'm asking you, do you know, is there a solution? What would your solution be to that problem, huh?
She's saying facilities. Is that, am I hearing?
But,
Sure.
so how do you get, I know, but what I'm saying is, how do you get to the facilities? Is it about rates for childcare? Is it about encouraging the private sector to do, I mean,
So that's
what is the answer?
That's a really good question, first off. And I'm going to say pretty much the same thing she said, but in a slightly different way, and so maybe it'll help. Right now, pre-K dollars are only allowed to be used for funding slots. They're not allowed to be used for capital outlay, building buildings, building pre-K centers.
Okay.
And I'm not saying they should be or shouldn't be.
No, you're answering a question.
But that is one potential way to increase capacity. Obviously, we're in a situation where supply doesn't exactly equal demand, right? We've got 5,000 children. I think I'm a good example. I have a 4-year-old, and
Congratulations.
live in West Cobb, and we applied for a pre-K slot at one center, and my wife said, if we don't get that, we're just going to go pay for private pre-K. And so
what I
we want to know
assumed.
how many of me are on the pre-K waiting list versus how many people actually waiting that need childcare. So when we get this study back from the Carl Vinson Institute and we can answer that question, I think that will make more clear the answer to the question you asked, which is,
That makes
what do we do
immense
about it?
sense.
Does that make sense?
That's very helpful, and I really admire what you both just said, because oftentimes we get, as legislators, here's what happens: we get a a piece of data that may be a fact. For example, someone may say there are 5,000 children on the waiting list for pre-K in Georgia. Period.
But what does that mean, right?
You're doing a horrible job with childcare in Georgia. You know, we're failing, and we may think, well, maybe there's a solution here, which is why you're here today. We want to know, is pre-K a challenge to this workforce crisis? What you're telling us is the rest of the story. And by the way, we should always be this way. We should look at the facts on both sides. And what you're telling us is that doesn't necessarily mean there's 5,000 people that can't get childcare. You choose to go somewhere else, which is what I assumed from the conversation. I was sitting here thinking, almost certainly that's the case.
But we're trying to dig deeper and figure out what is the number and what does it mean.
Yeah,
and so she's talking about they're doing focus groups with parents.
That's
that are on
great.
Pre-K waiting lists. They're doing surveys, online phone calls, things like that. And we hope to be able to use that data of whoever we survey or focus group, extract
That's
it to
great.
the population and try to learn more.
So you don't
And-
know the answer today, but y'all will soon, and that's
Right.
great. That's fantastic. Maybe by January we'll know what really is the waiting list. Because there are certain people that, if you want to send your kid to your church day program, that's what you're going to do anyway. That's where
That's
you
where
want them
my
to be.
daughter is.
Yeah, I assumed that, and that's where mine went. To my church. So anyway.
So one of the things I would add to that we do know is that the likelihood that you're going to use a pre-K slot is going to be connected to your ability to also access tuition-based programs. So to bring it back kind of to the caregiver population, these are families that probably would take advantage of a pre-K slot because it is going to support their, having a program that's not going to be of charge. And so lots of times it may be directly related to a family's ability to pay for an alternative option for preschool. So.
Gotcha. Okay. Question from Representative Donahue for both of you, if you don't mind.
And I always start off, I have a good-looking 4-year-old that's looking to go there. We've got to make
I'll have
sure
to
we
work
all.
on that.
I know it. Pre-K is still vouchers, correct?
So our pre-K program, the funding actually goes to the program, and then families apply to the program of their choice.
Right. And when I first ran for office, back when Robert E. Lee was a young man, it seems like, there were 7 in a race. Voucher, that was a dirty word. And I was the only one that researched and stood up and said, well, we're already using vouchers today in pre-K. Basically, is that still true, though?
So In our CAPS program, we specifically use more of a voucher style program, which means a family applies and they get a scholarship that then they take to a program. In our pre-K program, is really semantics. What we do is we fund programs apply to us, then we fund the program, so we fund a class, and then families go to the program of choice. So
Thank you.
So we fund, just to be clear, we fund a classroom with 22 slots in it. It's the private pre-K program's job to sell those slots to the public.
yeah.
But I think, good point, Representative, because the money follows the child, which is essentially a voucher. We do the same thing as we do with special needs children in this state, with the special needs scholarship is essentially a voucher. So, very good point. Thank y'all. Y'all have been enormously helpful.
Thank you.
Thank you so much for being here. Okay. I think that is all of the departments. Is there any other department that might be here? That those are the ones we invited, and y'all have all been so helpful. All right, so now we have several people that want to. Here's what we're going to do, guys, and got to look over here at the boss here. So are we going to take a break in between at some point, or we got a shorter meeting? All right, good. So we're going to go ahead and take. We've got 5 people who want to present. The presentation is recommendations only. So that should be short and sweet. Tell us what you, we all know the problem. What do you think we could do to make the problem better? We're going to hear from several of those, 5 that are signed up, but any others that choose to do so. And then what we're going to do is talk, I think, a little bit amongst ourselves about the recommendations, and then probably break and do that on our own, okay? So we'll do that collectively, and then we'll probably do that amongst ourselves to try to prioritize and hone some of the recommendations down, if that makes sense. Okay, so first we have Mr. Doug Luter. Am I pronouncing that right?
Yes.
Hey, Doug.
And if I could, I'd like to give Kathy Floyd my spot because she has another meeting to get to.
Oh, yeah. Oh, good. Yeah. Oh, and we didn't have Kathy on the agenda. Okay. Oh, yeah, she is. Okay. Yeah, you gonna move up? Good. Yeah, good. Thank you, Kathy. And I really wanted Kathy to be here, because, listen, folks, her organization is as involved as any in this issue.
Thank you.
Serving individuals who are aging in this state like never before. And we also heard a lot of information on that at the biennial about our Alzheimer's rates and dementias and our growing aging population. I think we are the 11th fastest growing state for
Yep.
seniors in the
Yep.
country. So,
Yep.
so thank you for being here, Ms.
Certainly,
Floyd.
and thank you to my friends, Doug and to Dave, that I asked if I could go first because I've got a meeting out at GBI at 11. So
Absolutely. Thank you for
very
being here.
much.
Please.
Mr. Chairman, you had asked me to share a couple of things about work that's been gone on to establish a caregiver registry already.
Yes.
And I wanted to share that the Georgia Council on Aging, that I'm the executive director of, worked to put together a caregiver registry, which really, once the Department of Community Health got involved, and their expertise evolved into the fingerprinting and then the caregiver registry that goes with that. So we are very, very pleased with that development. But we had done some work before that in caregiver registries. And so we looked at, of course, the CNA registry and why that came into being. And that was established because of federal regulation. Federal regulation requires that every state have a nurse aid registry. Now, Georgia decided to make that include CNAs. And so that is how the CNA registry came to be. And DCH maintains that, and they contract with Alliant to actually maintain that. And so other states have decided to have different nurse aides be part of that registry. So we had looked at whether the CNA registry could be expanded or not. And of course, what you run into, of course, is you need money to do that. And the federal funds, as far as I know, that come down are just enough to support the current CNA registry. So if you wanted to expand that, it will take funds. But that is why the CNA registry is where it is now. And that is something that we found out through our work group and dealing with stakeholders. The other thing that I wanted to share is, as part of the GARD Advisory Council, which is the Georgia Alzheimer's and Related Dementia Advisory Council, one of the recommendations that has come out of that group and the workforce committee that has put a lot of effort in is the proposal that there be a direct care workforce registry. So it's right in line with what you were talking about, the need for this caregiver. And their information is that Iowa and Illinois already have such a vehicle. And so those are two that we know that could be looked at and how they have set up. And I know that Iowa started as the CNA registry, and then they have added to it as you look at all the different categories that we've heard about, whether you're working with which population and that kind of thing. So I just wanted to share that information and share that there's a lot of support for this, for what you're talking about here.
That is very helpful, and it was helpful to get it straight from you, because I know the Georgia Council on Aging, you guys have advocated for that issue. I mean, going way back, y'all were early advocates for a registry. I think what we've been hearing now is that a registry, and we're going to have one for fingerprinting, and we have one for CNAs. But if we had the ideas that are coming in suggest that if we had a broader registry, that it might be helpful to not only consumers and advocates, but it might be helpful to providers and individuals who would have, the majority of these caregivers are not CNAs.
Right.
They're whatever we call them, as I mentioned in the first meeting, whether we call them DSPs or
PCAs.
Personal care aides, or it doesn't matter. They're all, they're caregivers. But if we captured everybody, and that there might be some portability with that, so they could go, because let's face it, most of these caregivers are working 2 and 3 jobs.
Right.
And especially since the loss of the companion exemption, where they can't work more than, or providers aren't going to work them more than overtime because they can't afford to pay them overtime. So they work here, and then they go here, and they work. They're still working the same hours. They're just having to go to 3 different people to do it.
Right.
And so it would allow them some portability. That would reduce the burden on providers, first of all, which will reduce costs, which should lead ultimately to being able to pay people better. But moreover, it would allow them to go to work sooner. I think it'd be helpful to the individual caregiver. So that has been the conversation, and it sounds like, just to reiterate what you're saying, that other states have done this, and you could take that CNA registry, and we could beef it up, broaden it, add these different
categories,
things that we track, if you will, categories, good way to put it, that we track. But it would cost more, and I'm looking at Brandy over there, but it would cost more, I guess, because there would be a lot more folks on it.
Right.
So it would be a fiscal hit to the budget.
Right.
Okay.
Right.
Gotcha.
Right.
Very helpful. Any questions about a caregiver registry? Nope.
Okay.
Thank you very much, Kathy.
Thank you.
Thank
and
you.
if I can just give a plug for
Please.
Doug, who is the one 3 or 4 years ago that is an active member of our coalition and brought this idea first. So it makes great sense for him to go next to talk to you. So
Great. Okay.
Thank you.
All right. Thank you, Kathy. All right, Doug.
Thank you, Kathy, for that fine lead-in. How about that? Good. Well, thank you very much for allowing me to be here today. And as Kathy mentioned, this has been something I've been passionate about for a long time, and it was wonderful that a registry was actually started, and it's a great step having the fingerprinting, but I think it's a far cry from a full solution that we're looking for to ultimately. There's 2 problems that I want to address. How do we attract, incentivize, and retain more caregivers into the caregiving field? Because as we all know, there's a shortage. But how do we also filter out those bad eggs to reduce neglect and abuse and exploitation of our seniors? The vision I have that I've been working on for a couple years is something I refer to as a caregiver empowerment organization, a CEO, which is basically a rating and credentialing organization. And to put it across in the most simple of terms, I'd like an organization that rates caregivers and basically gives them a 1 to 5 rating. Just like Uber, just like Google. Who goes out and hires anybody that has a 1 or 2 star rating? Anybody? Nobody. The reality is, if we can rate caregivers on 5 or 6 simple criteria, do they show up on time? Were they professional? Were they compassionate? Did they provide good care? And get that feedback ultimately from the consumers. I think also from the agencies, but there's probably some things legalities we'd have to worry about coming from the employers, but definitely from the consumers. And if we had an organization where anybody could go on when considering a caregiver and look at their star rating, it's going to filter out those bad eggs. You know, my motto is reward the best, filter out the rest. And for the caregivers that maintain and achieve those 4 and 5 star ratings, what we need is some of these programs that I learned about today. Let's give them child care credits. Let's give them transportation credits. Let's give them education credits. Let's lift them up. Things that aren't necessarily just another dollar in their pocket, which that would be wonderful too. But can we pull these federal and state agencies together with those types of incentive programs to prioritize the caregivers that get those 4 and 5 star ratings, to fast track them into those child care programs and into those nursing programs and transportation programs, because that's what they need. That is putting money in their pocket. That is giving that leg up to them to help them down that path. Now, some of my ideas on how to do that, I think it would maybe require that the aggregator for the EVV program, who's going to be, bringing in all that information, could share some of that with this type of organization so they could have the punctuality factor brought in automatically. But it would probably require some type of surveying capacity where we actually have to reach out to the consumers, to the people receiving the care, as electronically as possible, because that would be way more efficient, but it might require some good old-fashioned phone calls, and try to somehow come up with a way to in a very non-biased way, get that 5 and those 4 and 5, 1 through 5 star ratings. And of course, the caregivers would probably also need a way to have some due process if they felt like their rating was wrong.
Great point. How do we pay for it? Anytime I look at buying something, now I go and look at reviews. Mm-hmm. Looks great. Mm-hmm. And after you have a 3-star view, you think, okay, what was wrong? Then you see a 1 or 2, I'm not going to buy it. However, that's a mechanism to where if you're looking on Google or whatever that is put through a website, do you want a board to be established that's going to look over something like this? They're going to give the ratings? Is that what you're trying to come up with?
I think you'd have to come up with a standard questionnaire and basically ask consumers, you need to rate your caregiver 1 through 5 on punctuality, although we could get that from the EVV for the Medicaid providers.
Okay.
We want you to rate your caregiver 1 through 5 on their professionalism, their compassion, their quality of care. Again, I think you keep it to the primary criteria that I think as home care providers really make a good caregiver. So,
Thank you. Very, that's one we haven't heard yet. Very interesting.
And-
We have a question from Representative Mathiak, Doug.
Through the Council on Aging, did Kathy leave already?
Yeah, she had to step out.
Well, you'll probably know. Is there any software already available that we could do that survey with clients?
there is
No.
lots of surveying software out there already. Obviously,
Right,
Uber,
right.
all these companies
SurveyMonkey.
do it. So I think tailoring one to this, it would be more the necessity to form an organization that kind of manages this process. And the beauty of this is that it doesn't have to be just Georgia specific. Something like this could go across the country and could really go across the planet for that matter, and really help raise those good caregivers up and give people some good insight to whether or not they want to hire that person. but the software's out there.
Representative Donahue again.
With the point you just made, wouldn't you prefer that you have a rating system by your peers within your group that would set this up? I owned a logistics company many years. Looking into that, I do not need government always telling me what's best for me. I knew what was the best avenue to get to certain places. What I'm saying, I agree with what you're saying. I just want to know the best practice without more government money thrown at something and another board created, because I have two buddies that I want to put on a board, and the stuff that I see bad, I would want to see it within your group. And if that's something that I would encourage you to step forward on, try to set this up, and whoever the guys in your group that you would really trust on that, y'all would come up with the idea, the concept would be fulfilled in the next year, and then we could start that process.
No, I agree. But ultimately, we would need the buy-in. I think it would be most successful if the state required information to be reciprocated with this, some of the basic information like the EVV information to help come up with those ratings.
And I think, and we'll think it through. It's something, it's an idea that's worthy of thought. Obviously, there could be some real privacy issues, and there, I can imagine there'd be a lot of issues there as well. Thinking as an employer, but thank you, sir. Thank you for being here.
You're very welcome.
Thank you very much.
Thank you.
Mr. Dave Lamb, again, recommendations today, and I appreciate you being here this morning.
Well, I appreciate the opportunity. Give me a minute to load. Y'all should have a copy of my presentation.
Okay. The blue folder. Oh, that's right. Yeah.
All right, help me here. Got it?
You got it?
Yeah. Well, it said it had it. Oh.
Right there.
I'm
That third one. No, not that one. That one.
Got it. I'm used to always having that in the upper right-hand corner. Sorry. Okay, I want to thank y'all again for what you've done. This is actually my third time standing before you. I'm going to be much quicker today, but from what you've heard, you've had a lot of data. Now, I know there's been a little bit more data this morning, and a lot of that's important. And when you talk about the 1,491 CNA students that are currently enrolled, that is 2% or less than 2% of the current CNA registry in the state of Georgia. So that's an eye-opener right there, that we don't have enough out there. We've already talked about, and I've given you some of these things as a reminder from last time so you can see rates. But we believe that there is a series of multiple solutions, and again, these are coming from CareMaster as a provider's point of view. Part of it has to do with our current regulations, training programs. I'm not going to duplicate what's already been talked about. I think there's an ability to increase Medicaid waiver program efficiencies to generate more funds, but to also help with turnover. There are a lot of other caregiver issues, and then reimbursement rates. The first thing, House Bill 183, that was passed and became law effective July 1st of 2015, is still not incorporated in the regulations for private home care providers in the state of Georgia. And there's 1,244 licensed providers as of one day last week. So that requires that caregivers have to be W-2 employees. The regulations tell them we have to have to supervise. So, where does that present a problem? Encountered a $12 competitive pay rate. And I've listed before you what our payroll burden is, over 15%. And that includes Social Security, state unemployment tax, Fed unemployment tax, FUI and SUI, for those of you into acronyms, workers' compensation, and now drive time. And drive time is something that has to do with the loss of the companion services exemption. But over $15. So when we meet that $12 pay rate, it costs us $13.83. It really hurts our margin. Or when we compete based on cost, the pay rate is $10.42. Where are they going to go to work? They're going to go for the $12 an hour, but they're going to go to work for a provider that is violating the law. So it's an unlevel playing field, if you will. All right, training, heard a lot about that, and I'm glad there's a lot of attention to it. Soft skills have already been discussed. I like the Georgia Department of Labor, the Georgia BEST program that is incorporated in a lot of school systems across the state. For instance, in Griffin, our Griffin Region College and Career Academy, students go by the Georgia BEST program, and they have to do that in order to graduate. I mean, they have to meet those measures. I think there needs to be more expansion on dementia and related disorders, more training. And we've already heard, but in the home setting. I also think that there needs to be an incentive for in-house training. We have shown, based on our experience, we can reduce turnover. But that is very costly doing it in-house. There needs to be some attention or some funds set available for tax incentives or grants. I think that would be most helpful, and it needs to be for PRN. A lot of those are just for full-time employees. And the other thing we'd like to see is that the Department of Labor offices target caregivers in job openings and have some signage that would help identify those shortages. That reaches a lot of folks. Efficiencies in Medicaid programs. We think that EVV is a great start to drive home care more to real time. And the whole intent from our perspective is that EVV needs to do things to allow us to improve client outcomes. For years, all we talk about is attendance or is the paperwork right. Well, EVV takes care of a lot of that, but the important part is what's happening to the client. All this turnover minimizes or reduces continuity of care. And in the healthcare setting, no matter what the level of service, you need continuity of care. So we think that that's important. We also think that there ought to be some funding for assistive technology, more than just displaying it in AAAs and senior centers, but assistive technology and wearables that can generate client data. You can do fall protection, or both protection, but you can predict falls based on gait analysis. The Chinese are now, all this Google talk, the Chinese are using cameras and identifying folks by their gait. So it is an identifiable item and something that can reduce healthcare costs and make it easier to fund reimbursement rates. The other thing is that EVV we've run into resistance because we have installed essentially a year earlier than the regulations require. It was originally set for January the 1st of 2019. It's been delayed a year. We have clients and caregivers say, I'm not going to do it. I'm going to take the client away from you and go to another agency that's not doing EVV. Well, everybody's going to be doing EVV within a year, but there again, you've got folks being moved for well, for reasons that just don't make sense. And then the other thing is to recognize that home and community-based services can serve more Georgians. All right, I think that we need to look at a different way of assigning clients. There was years, and Chairman Petrie, as being a fellow provider, know all about the rotation log, but what we ended up doing is creating silos all across the state of clients. And what you created was just a few clients here and providers providing just one or two clients in a small area. So therefore, the caregiver does not get enough hours. Need to be some kind of geographic basis. I call it a facilities model, where you drive, rather than walk down a hall and the client's in this room and that room, you drive down a highway or you go 5 or 10 miles and you use your scheduling software to schedule them to various houses, but to give your caregivers enough hours so they don't leave.
Mr. Lamb, let me stop you for 1 minute to clarify, to make sure I'm following you, and also for my colleagues here to make sure. So EVV, because we have all these acronyms, is electronic visit verification, and that has been mandated and is going to be very helpful, as you point out, to get more efficiencies out of caregivers when they're out in the field. It is going to make sure that they are on site making that visit. We know when they go, we know when they leave. It's not just on paper. So I just wanted to make sure that everybody knows that. And then I want to make sure I'm following you. So you're talking about trying to cluster clients in geographic areas in order to make the use of those caregivers more efficient. Is that what you're speaking to now when you talk about a facilities model? Okay, thank you.
Dave, that's the assignment, when you're saying assigning the clients, that's through your facility, correct? In the geographic area, so it's a time?
Well, I'm saying, look at a rural area, look at a county,
Right.
look at it as a facility. Let's say there's 20 folks being provided services there.
Right.
Rather than having 6 or 8 providers in there, which the previous model created, maybe a couple providers for that county, so that you can concentrate, and then you've got a workforce that's getting 40 hours a week. I mean, we would be willing to set up with drive time and all that 40-hour work weeks where those clients exist. What happens, and there's an example, you'll see an arrow on it, that's Box Springs, Georgia, 31 miles from Columbus. We had a dear sweet lady there that we provided services for 3 times. 3 times, the caregiver up and left went to take full-time employment in Columbus. We were only getting, I think, 24 hours a day most of the time. So it was rebrokered because we didn't have anybody in Box Springs.
The question.
That
so
client came back to us 3 times until she
Okay,
finally
Dave.
died.
So to allow that, again, because our focus is, what are the solutions? What are your recommendations? To do that, and that is a recommendation. You've just made one. But to do that, how would you do that? That would require almost some kind of RFP. In other words, if you want to capture, Butler, Box Springs is, I forget what county that is, but it's in the middle of nowhere. It's not Muskogee. It's east of Muskogee. But let's say it's Eccles County. If you want to serve a very rural setting and you want to be the provider that captures what limited cases are there to make it viable and to use a caregiver more efficiently, how does that happen? Do you make a proposal? Because every provider has to have the same opportunity to bid for it, if you will. So just explain that further so we can understand your recommendation.
My thought on that, in talking with folks at DCH and Medicaid, there would need to be some type of trial basis and arrange that with CMS. But in Box Springs, in that area, there were other folks receiving services, but they were provided by other folks. And it turned out that there was a lot of turnover with those other clients. So my plan would say, I mean, obviously, as providers, we would have to say, well, I can do this area, or we have caregivers. Not all of us have strong caregiver base throughout the state. I mean, we happen to be a statewide provider, but there are areas where we're blessed with more caregivers than in other areas. I think it just doesn't make sense to go down the same road and have two providers providing 15, 20 hours a week to two different caregivers and two different clients when you can book those hours together. And that way you reduce caregiver turnover and improve continuity of care for multiple clients.
They'd have more time too,
Correct.
rather than driving.
Absolutely.
More care time rather than
Yeah.
driving time.
And I suspect, I mean, from small samples that we've seen, that is doable based on a lot of the rural areas in particular in the state. In the urban areas, it's not as big of an issue.
Okay.
Okay, as far as reimbursement rates, this is a repeat from last time, but it shows how competitive home and community-based services are, and that in Georgia, we can take care of 3.5 Georgians for every one that's in a skilled nursing facility, and that it's important to consider and to expand those to give more opportunities as well, again, to build hours. The problem is that part-time or PRN model does not work. We need to be approaching it from a full-time model to give folks full-time hours. And then I'd like to kind of end with pay rates, and we've talked about that before, but one thing I want to point out to you is that we have a lot of caregivers that are on public assistance, and they will refuse hours because they don't want to go over a certain threshold. And I think that hurts. I've also shared with you a repeat from that we've had other unfunded items to go in, and just share with you as a reminder of what's happening national-wise funding for adults 65 and over, that it's been a real change. So again, I'd like to thank you for what you're doing. I know that these 3 committee meetings that you've had and your travel time, there's been a lot of effort spent into it, but this is something that is very important. We need to stabilize this workforce. And I think that the longer we wait, the more difficult it is going to be on continuity of care.
Question from Representative Donahue.
Let me ask you a question here. In the back, Dawn, you testified, and I apologize for a second, it's something I've been wanting to ask since last time. On your needs, how long have you had your needs in your situation? I'm not assuming anything's why I'm asking.
You mean how long have I required this?
A wheelchair and assistance.
Certainly. So I started using, I have a progressive neuromuscular disability. So I started using a wheelchair part-time when I entered school. Full-time wheelchair usage is at age 9. But I've always essentially required, care in order to do my activities of daily living. So that has, that's something I don't remember not needing. Those things have increased over time. So for example, I started using a ventilator a couple of years ago, that kind of thing. I was able to feed myself 5 years ago, now I cannot. So does that answer your question?
It does, and one of the things I want to know is, I ask the gentleman that's with you as a caretaker, he is with you 8 hours a day, sometimes 10, sometimes 12, or?
I do
Okay. And with that, there's a pretty high cost into this. Do you receive assistance to pay for everything through the state, the federal government, or do you just have the means where you're able to do this?
It's a very expensive undertaking, and I can say even with a great full-time job, I could not afford my care.
Right.
And so I use the independent care waiver, to fund my care.
Yes, ma'am. Thank you. What would you estimate your cost is per year? Just a wild estimate.
What I can tell you is, and I don't know, Brandy, you're here from DCA. I think, isn't that the cap for ICWP, is it around?
I'm not immediately familiar with that.
Okay, I can get you that information, but, because I don't wanna speak, incorrectly, but I think it varies, for individuals. I mean, there's people that get maybe 8 hours of care a day, and then there's, maybe some that get up to, 12, 18 hours a day, maybe a few that have 24.
Okay. Thank you very much.
Certainly.
It's based upon level of care, and the reimbursement rate maximum, I believe, is slightly over $20 an hour for the.
That's correct. ICWP is still the lowest reimbursed waiver, but he's right, it's around, I believe 20 or 21.
Thank you, sir. Okay, Ms. Diane Willish with UCP. Very, very fine, reputable organization. You and me both. Okay, Ms. Willish is here representing the SPAD, the Service Providers Association, and also the United Cerebral Palsy, as I mentioned.
Yes, thank you. Thank you, Chairman and committee members, for allowing us an opportunity to share with you some ideas, recommendations that we have as you move forward and work towards your final report. What we've given you is three kind of areas of opportunity as we see them to improve our capacity to recruit and retain direct support professionals in the IDD world. That's what the folks that SPAD represents. So the first thing we want to talk about is, you may know that there's a parallel committee working out of the Senate that's looking at oversight of provider organizations in the IDD world and how regulations and oversight can be streamlined, because right now it's very cumbersome and so forth. So what we found, and we've highlighted here, is that when we do exit surveys of direct support professionals, one of the reasons often that they leave the work, aside from money, is the complexity of the paperwork and demands on their job in an 8-hour shift, or however long, a 12-hour shift. So we think there's an opportunity here that if the committee saw fit to kind of to support the notion that we need to simplify their work that isn't really caregiving. That obviously there needs to be records, there needs to be documentation, but the complexity of what they're required to do, and we talked about earlier the reading level of some of our staff and the writing level of some of our folks. So I think if it would be in the committee's purview to kind of, and desire to dovetail to that and look at some recommendations in that regard. Also, we have many members that are surveyors for accreditation bodies, so they travel around the country and look at services at other like organizations. And almost to a person in our membership of people that do that, and I have the pleasure of working with United Cerebral Palsy in 2 states. The other one is South Carolina. And we can tell you that no other state operating waiver services has the complexity of documentation that's required of essentially unskilled support staff. Great caregivers, big hearts, but writing and documentation tough. So if you would consider doing that. In the next area of consideration is increase in wages, and I think obviously you've heard lots of information about that. While in this document, we give you a recommendation of how that might be done with an adjustment in rates, which then would be required to be passed on to direct support staff. This is a model that's worked in other states that we're aware of. It may not be the ideal way to do it here. It's just an idea. Another idea might be is you do a rate adjustment that equals the equivalent of, let's say, $1 with a strong encouragement of passing on that increase to the direct support staff. I think the expectation to mandate something probably is not as palatable as making an adjustment in rates, and then with the caveat that that's your recommendation of how to pass that along or what to do with those funds. So I just mentioned that $1 would be would cost us the state about $32.40 to generate enough resources. So food for thought in that regard. Then we have some recommendations that I'd like to expand a little bit upon besides what is written in the document around training and development of a career path, which is really critical aside from money and streamlining the work. Is there opportunity for me to progress? And I think we've talked early this morning with other presenters about opportunities, for example, with the CNA arena. I think if we could examine not only the clinical practicums that CNA students out of the Voc schools may need to do, and currently they're in skilled nursing facilities, so hospitals, nursing homes, assisted living are where those opportunities exist as approved opportunities. If we could expand home and community-based services as an opportunity to do clinical practice, we think we would, number one, interest people in the field, and potentially we'd be able to access a greater pool of individuals to do the work. The other piece of this is that it is our belief that the CNA program, if it's not in the Voc schools, technical schools, you can take it, you can become a CNA under a hospital umbrella, under a nursing home umbrella. Community waiver services are not allowed to train their own CNAs. And if that rule could be amended to give us the opportunity, if you saw fit, to train your personnel if they wanted to. So, but we don't even have the opportunity to offer that to our staff, that we hire someone and say, you work with us, we will take you through a certification program. So we would like to see that opportunity expanded so that provider employers could do that with that certification with their staff as well. And Mr. Chairman, you mentioned the notion of including proxy care training in the CNA program in the Voc Tech schools as an opportunity, and we certainly are really supportive of any way that can help us manage the training of folks, particularly with respect to medication administration. And along those lines, we might want to suggest that consideration be given. There presently is a certified medication aid program operated through HFR that's available to assisted living facilities. And if the administration of medication for IDD individuals in home and community-based services could be handled under that certification program, that would be, again, an enormous efficiency, save us a lot of resources that then we could pass on in wages to direct support people. We're supportive, of course, of the notion of a registry, and again, to the chairman's remarks about an expanded registry that could realize some efficiencies with certifications and training and all that sort of documentation within a registry so that people could move easily from employer to employer, also would save the hiring employer. I think that would be wonderful. I think that the background check that through the Senate Bill 406 that's been passed and is being worked on is a huge accomplishment and so very important. But I think that if we could take yet another step, and it sounded to me like it would need to be a different registry because it's not as expansive, we would be very much appreciative of that kind of thing going on, that kind of registry being developed. And just a comment about the GED issue, and just a fact is that you don't need a GED. I heard them say to go to the Voc Tech School and become a CNA, but you cannot be hired in home and community-based services without a GED or a high school diploma. So we would propose that that regulation be reconsidered and allow us a little bit of latitude with who we can hire. If someone with a GED is competent enough to enter our Voc Tech schools to be trained as a CNA, I would believe that they would be competent enough to work in our arena. Another piece of that is that for some portions of our work in the community, some of the staff in some settings are required to take what's called a TOEFL, which is about language fluency and competency. That's a requirement of us hiring them. So they've at least had that. So I think that if we could reconsider this whole GED notion, it would be helpful. I mean, you still want to hire competent people, but that's in your recruitment and interviewing process. And the final thing that I would mention is that I really appreciated, actually, I'm going to ask if I can get a copy of the slides from Susan with respect to all the child care opportunities. I want to make sure that our staff and our membership staff all are aware of those opportunities, that they don't access them, that they can. But just some consideration, and this is a big issue, I think, and I don't have an answer to it, but childcare needs to be 24/7. We operate services 24/7, and if staff cannot get childcare for an 11 to 7 shift, then we've really got, that hampers our ability to hire people as well. I wish I had a magic bullet or a really great solution for that. The only thing I can think of is that school-based programs maybe could be expanded. I know that some hospitals in urban areas and so forth open up childcare on site. So maybe, you know, the facility is there, the school is there. Is there an opportunity to pilot a program where they would offer it on a 24/7 basis? Just a thought. So that's it. I'm happy to answer any questions.
Well, that was an excellent summary, and a lot of good recommendations, and we do have a question from Representative Mathiak.
This is probably a really silly question.
Oh, no.
How do people find out about services? Where do you go? How do you find out from your medical doctor? Do you find out from DFACS? Do you find out where?
Yeah, I
where do you find out about all this?
Really, kind of sadly, it's a very complicated system.
I was afraid you were gonna say
And I guess, we collectively, all of us as a community of people interested in supporting people with disabilities, don't do a very good job of public education so that people know where to go to get what they need. However, to specifically answer your question, the entree into the system is through a regional office, which are 6 of them around the state. That is the beginning point of getting into home and community-based services or some state-funded services.
Thank you.
Yeah, but, I think we all could do better about helping people understand how to do that.
Representative Donahue.
You're exactly right. Let me make a suggestion. Dave's done an outstanding job. Each one of you have brought great information to us. However, you need to start looking at speaking at Rotary clubs, key clubs, any type of chamber meetings. Tomorrow we'll be doing eggs and issues. We'll have about 600 people. They'll ask us all kind of questions. Most are nonsense. When you're there, you have the opportunity to ask that person a question. You will get an answer most of the time, hopefully truthfully. Sometimes it's not that way. I don't assume things. I like to know facts. If you are speaking and I'm listening to you at the Key Club or whatever, I'm going to come up and want information. You provided that. Most people never see this, never hear it. You're not on the front page. Everybody always looks at the little bad negative. News is showing a lady slapping a lady around and doing stuff like that. I've been there in LaGrange. many years ago with my grandmother. But you know, one bad apple, unfortunately, is the one they're going to look at. I used to teach young people when I coached them in ball, if you throw the second punch, you'll be the one caught and penalized. But I do ask that in the future you really start putting in your organization to go and speak to these groups, because these are business people. Most of them will come up and they'll have questions they never knew that were there, and that will help y'all also.
Thank you, I appreciate that. Sage advice, certainly.
Thank you. Very helpful. All right, Miss Maureen Kelly. And that is the last person, by the way, folks, we have listed to speak to recommendations this morning.
Well, thank you for your time, and I'll be brief. I came before you in the past as a president of the Thanks Mom and Dad Fund and the head of the coalition of many of the providers that you've heard from over the past few weeks who have talked about these issues. But I come before you today as an individual, albeit with my experience at the Cabinet on Aging and the Georgia Council on Aging, and having worked at an area agency on aging, because I've been out having holiday fun in New York and traveling. So I haven't had an opportunity to speak to the coalition, so I don't presume to speak for them. But I raise a question that has become a thorn in my side just thinking about this. You know, the Aging Network can very definitely assist you with many of these issues in terms of a concerted effort around offering more internships and making sure that the universities are aware of the internships in home and community-based settings, creating the career ladders and lattices, and even rehiring retired nurses. But if in fact we must send nurses out to do the assessments for people to get home and community-based services under the waivers in Georgia, and if in fact we are serious about doing something, and I do recognize this committee as doing a great job taking seriously this crisis in the shortages of the workforce in home and community-based services. But with all of these facts before us, and Representative Donahue, I agree with you that I do not, like, having worked in government, like to see dollars go out the door at something that there's not going to be an ROI and in truth, effectively serving people. But at the same time, we know there's caps on the number of nurses that are taken into our Georgia universities, and we also know that we're all fighting over the same nurses in our nursing homes and in our hospitals and home and community-based services. So we either need to take a serious look at raising those caps, which I realize is attached to funding. And the only other thing probably to take a look at that budget and perhaps consider raising those caps, perhaps tied to some type of forgiveness for people who are going to stay in Georgia, work in Georgia, and deliberately in the home and community-based settings as a requirement. And the only other thing that I can think of is that we change the requirement of having to have a nurse, because we know that's the biggest backlog of getting people served under the waivers in home and community-based settings, is that visit from a nurse to do the assessment first. And in fact, if we modified in any way the requirement that would allow some presumptive eligibility based on the scores, the valid scores that come out of the ADRC screenings, coupled with an initial visit from a social worker and then validated later by the nurse. But I honestly can't tell you today which one of those things are going to be easier for you to affect. I can help you look for some of those solutions, but I just want to bring that before you because I know that you are determined to do something about this, and yet if that is the greatest backlog to getting those services flowing to individuals, we have to look at one or the other, or perhaps both. Thank you.
Thank you. Very good recommendations. All right. We have heard, is there anyone else here that would like to speak before we call it quits? Yes, ma'am. Come forward and do so. We are going to, it is now 11 No, I'm wrong. Right? My clock's 11:13. I'm right there. Okay, and we are going to hear from this last.
Yes, thank you, Chairman Petrie. I'm Mary Lee Boatwright Quinn, and I am Manager of Advocacy and Public Policy at the Alzheimer's Association Georgia chapter, and also founder and chair of the National Aging in Place Council Greater Atlanta chapter that Doug is from and presented the registry issued to the Council on Aging years ago on behalf of. But I am also a part of GUARD and the Workforce Development Committee there that came forth with the recommendation of creating a direct care worker registry. And I just wanted to share the Alzheimer's Association's support of that effort, but that it be an expanded registry, that it would include any caregiver who provided help with ADLs, because there are so many more than certified nursing assistants out there in the workforce, like a home care aide, adult day care worker, med techs. And so in order to really cover that whole gamut of care providers across this continuum of care, I think it needs to be expanded. But having a centralized database would, actually the woman before me spoke to this, that having that centralized database could reduce the cost to some of the direct care worker employers, because then they won't have to retrain, and they're always talking about rates and the low rates that we have, and that would help reduce their costs. So having that centralized database that the state would recognize, and that maybe in the future could include the star rating that Doug was talking about. You know, you can start with a registry with certifications and background checks, and you can continue to expand that, which is what Illinois and Iowa have done. They started somewhere and then just kept expanding upon it. And in Iowa, out of creating a direct care worker registry, an association for caregivers was created, and that really helped with retention and just lifting up that profession to be a more legitimized profession for those direct care workers. So,
Thank
that's
you
all
so
I have
much.
to
That
say.
has certainly been a recurring theme. This registry has been a recurring theme from,
yes,
from
and
day
the one thing I
And
will
so,
add
thank you.
about training, you all mentioned in the tech schools the proxy caregiver training possibility. The Alzheimer's Association would also like to say, and I think there would others be in support of this, that we would love to see some competency-based dementia training certificate, because the numbers of people with dementia is skyrocketing, and that's going to be a huge impact on the direct care worker workforce. And so having dementia-specific training or certification would also help kind of give workers an incentivized, a reason to get further training, and perhaps be eventually, provided a higher level of rate of pay for that.
I think that's a great idea, and I can think of, behavioral challenges. There's all kind of things we could, if we had a real registry, we could have these ancillary certifications or coursework that we know someone has that might make them more valuable and lead to that whole ladder we've talked about. We have a quick question here from Representative Donahue.
Thank you. On the Alzheimer's, what is the biggest cause it's increasing every year in dementia? What have you found the number one thing?
Well, it's related to the change in the population, the increase in baby boomers, because the number of people over 65 that have cognitive impairment that leads to Alzheimer's or dementia is you have a higher risk when you're older. So because that population is increasing, that's a big reason, but there's a lot we still don't know, and dementia research is going on about that and why the numbers are increasing. But that is one of the things that people point to.
Maybe too many chemicals put in food and drink and stuff like that.
I'm not going to comment on any of that.
One of the things, a suggestion, when you're looking at, I think earlier we were looking at under the nursing, 100% was paid training and tuition at the technical schools. If we look at putting let's say you finish school, you're paid for your education, and you stay in an area of carekeeping for 5 years. we're going to help with other parts of your education. I could see something like that. We're trying to do that with our doctors now and physicians to let them understand that if you go to school here and stay here 5 years, you're going to probably stay here. You build friends and relationships. That would be something I think would be good to look at, that
Absolutely.
incentive.
And other incentives, as Doug mentioned, like childcare, tuition reimbursement to further their education, and
Right.
maybe even giving a priority on some of those childcare programs to direct care workers.
Well, they do that
Good
in
direct care
education with
workers.
teachers. I've noticed they said, we'll forgive so much of your school debt if you commit to stay within the system for 5 years. And I just think that's something that works.
Well, and I'm a social worker, and I've been in aging for 20 years and been in hospice and home care. And the nurses that I see that started as a CNA and worked their way up to be nurses are usually the better nurses. I'll just say that.
I agree with that. Thank you so much. Folks, here's what we're going to do. So we have gotten a great deal of data, a great deal of recommendations. I'm going to just briefly, I've kind of tried to put them into categories. We are going to break. We are going to go off to ourselves, and we are going to try to take all of these recommendations that we have and boil them down into the ones we think have the greatest potential and the ones we should prioritize. And so, but let me tell you what I've just roughly got here. They really, a lot of it relates to training, as y'all have heard here today, but not just today, in previous meetings. Training, childcare has been a recurring, I don't know that I see a whole lot of opportunity there for us to, do something today to impact it. But that is one of the categories, training, childcare, policies, as some of those that were just alluded to, policy changes, whether it relates to a registry or proxy caregiver training, and then, of course, rates. Those are kind of the, and of course, under training, I would put some of those things. We talked about, high school diplomas and making sure, we've got to make sure we capture everybody who wants to be a caregiver and has a heart to do this. And so those are the kind of the broader categories, and I've got multiple points, and Tara has multiple points under each of those. And so we appreciate all of you. We are going to take the balance of our time to hone these. We can't have 75 recommendations in this report, or it would not be effective. So we are going to try to come up with those we believe could be most effective and those that would be most palatable to either the legislature for statutory changes or to the departments for working to, as we have with some of the departments today, to talk about ways we might could tweak things to solve this problem. And so we appreciate all of you being here, and so many of you have followed us from day one, and we really appreciate that. This is an important issue, and I think everyone recognizes that. And thank you again.